did medicine here in Cambridge, then moved to as an ACF in the Maudsley, and now is splitting his life between doing the register in still at the Maudsley and doing the work on trust, if I'm right there, and the work on trust PhD on Catatonia. So he's the perfect person to explain us the new developments. We are extremely lucky, again, not only to have him, but he has just published this wonderful. I think I strongly recommend you to download this, a new guidelines about how to do when you have, or what to think and how to deal with someone with catatonia. I think I forgot to say the house rules, so if you don't mind, I will do that in a second. Yeah, please, all of you, mute your microphone and keep your cameras turned off during the talk. All the questions can be done through the chat, and you can send me the questions, and we can do the questions later on. And remember that all this talk will be recorded. So if you don't want your name to be edited, just send an email to Nicolina, not to me, and they will be doing all the work. So again, massive thanks and a big pleasure having you back, and I hope you don't go anymore, Jonathan. And please, the floor is yours, and welcome. Thank you.
Thank you so much for having me. It's delightful to be back in Cambridge, even virtually. Thank you for the very kind introduction. I hope that I can live up to the high standards of Emilio's talk from a couple of months ago. So, catatonia, I'm going to talk about where we are at the moment and where we are going next. So it will be a fairly clinical talk, but later on there will be some research findings. So in 1833, the Viennese physician George Pfändler described a young lady in her 20s who became depressed, became less mobile, stopped eating and drinking, started posturing bizarrely with her limbs, a little bit like in this picture here. And one day he went along and she was completely motionless, and he pronounced her dead. The girl was at a funeral and was buried shortly afterwards. Now, the only piece of luck that this poor young lady had was that she happened to be wearing a nice dress for her funeral. And the gravedigger thought that he would come back later that night and take it to sell it on. And to his shock, he found that she was still alive. So this girl probably had catatonia, and it's not just her, but there are lots of other people who continue to have this disorder. It was described and codified for the first time by Carl Ludwig Karlbaum in 1874, but it still exists. So what I'm going to do today is talk about our new British Association for Psychopharmacology catatonia guidelines, and focus on the assessment and treatment of the condition. Depending on how we're doing for time, we might have a little look at some of the subtypes of catatonia and special groups. And then we'll focus in on some of the work that we've been doing on investigations of catatonia, particularly blood-based inflammatory markers, structural MRI, and EEG. So the first half will be very clinical, and the second half will be more research-based. So, BAP catatonia guidelines, they were published a couple of weeks ago in the Journal of Psychopharmacology. They're BAP guidelines, but they've got experts from, I think, 5 different countries, 3 continents, and they reference about 500 citations. So a lot of evidence informed them, but it's worth saying that the quality of the evidence is not terribly high. Why the need for a guideline? Well, catatonia does confer a high morbidity compared to other patients with severe mental illness. Patients with catatonia in a number of studies have been shown to have a longer duration of admission and higher rates of various medical complications such as DVT, PE, pneumonia, pressure sores, sepsis, and neuroleptic malignant syndrome. And there's a risk of iatrogenic harm if we give these patients inappropriate treatment, which we'll mention later on. So, catatonia is a severe neuropsychiatric disorder. It affects movement, speech, and complex behavior. And often there's hyperactivity of the autonomic nervous system and some affective disturbance, particularly anxiety and fear. In the past, DSM and ICD considered catatonia essentially to be a type of schizophrenia. But the definition has broadened out now, and they've more or less converged on this idea that you need 3 catatonic signs for the diagnosis of catatonia. And the DSM ones are extreme agitation, ambitendency with these kind of hesitant movements, backwards and forwards, catalepsy, which is an induced movement disorder. So you elevate a patient's limb and it remains there against gravity. Well, it's particularly suspended with this background. Echolalia, which is where a patient repeats back what the examiner said to them. Echopraxia, where the movements of the examiner are mimicked. Grimacing, mannerisms, these abnormal, complex motor acts that are inappropriate to the context. Mutism, negativism, which is despite being able to perform a movement, not doing it when asked, or in fact doing the opposite of what's asked. Posturing is a little different from catalepsy, so it's a spontaneous movement disorder where a patient will put themselves in a position like the one in this photo. Rigidity, staring, stereotypies, which are purposeless, non-goal directed movements that are repeated. Stupor, a state of reduced responsiveness to the environment. Verbiduration, which is repeating words or phrases a little bit like a scratched record. And waxy flexibility, which is defined in different ways in different sources, but DSM and ICD consider it to be a steady and even resistance to movement. So when we synthesized the evidence, we considered it in terms of various categories, which will be familiar to you. So for causal relationships and treatments, we had RCTs at the top, all the way down to expert committees at the bottom. And for non-causal relationships, we had evidence from large representative population samples at the top, down to, again, expert committees at the bottom. And then for our recommendations, we went from A, directly based on category 1 evidence, to D, directly based on category 4 evidence, or extrapolated from evidence in one of the higher categories. And we had S, derived from a consensus view in the absence of systematic evidence. And to be upfront with you at the start, there were no category A recommendations, a handful of category Bs, but a lot more C, Ds, and S's. So, how do you assess catatonia? Well, it's worth thinking about the conditions that might underlie it. And there are medical or neurological conditions, and there are primary psychiatric conditions. Some of the more important medical conditions are autoimmune encephalitis, CNS infections, so for example, HIV affecting the brain, or herpes simplex virus encephalitis. Endocrine disorders, so hypothyroidism and Addison's. Focal CNS lesions, although it doesn't seem to be any particular part of the brain that seems convincingly preferentially affected. Medication and drug administration or withdrawal, so clinically some of the more common cases I see are related to clozapine withdrawal or benzodiazepine withdrawal, or sometimes cannabinoid intoxication. It's also worth noting that catatonia can be a presentation of non-convulsive status epilepticus. In terms of psychiatric conditions, catatonia is actually more common as a feature of a mood disorder, particularly severe psychotic depression, than it is of schizophrenia. Over the last 20 years, it's been recognized as a feature of autism spectrum disorder, and I'll talk a little bit about that later. Overall, Most cases are due to these more common psychiatric conditions. A figure of 80% has been given, 80% of cases of catatonia due to a primary psychiatric disorder. Has been given in one systematic review, but it really depends on what treatment setting you're practicing in. If you're in a general hospital, it's likely to be much closer to 50-50. You obviously need to take a history, which is easier said than done in catatonia. And so chasing relatives, friends, anyone really for a collateral is essential. You want to know about prior episodes of catatonia or neuroleptic movement syndrome, other psychiatric disorders they've had, past neurological history, a really detailed medication history. So there was a patient I was asked about a few weeks ago where she didn't have very much psychiatric history, just mild low-level depression, and she quite suddenly developed catatonia over a few days. And this was being attributed by some neurologists to a primary psychiatric disorder. But actually, when we really dug down into the medication history, there was withdrawal of a particular medication that she'd been on. In terms of recreational drugs, cannabinoids, ketamine can be triggers for catatonia. I've mentioned withdrawal of benzodiazepines and clozapine. Physical examination, you're trying to achieve several things. You obviously want to elicit the signs of catatonia, but you also want to assess for the potential complications of catatonia and any disorders that might have an etiological role in generating catatonia. Dehydration and AKI are common in catatonia, so you want to look for fluid volume status, temperature. If you're considering ECT, you want to conduct a cardiovascular examination. And I think if we're going to be giving patients high doses of benzodiazepines, we should conduct some respiratory examination. You want to look for focal neurological signs, examine the CARS for DVT, and look for pressure sores. In terms of rating instruments, there are a number. The two that have been validated are the Bush-Francis Catatonia Rating Scale, which is more commonly used, and there's also the Northoff Catatonia Rating Scale, which is probably more comprehensive but takes longer. It's helpful for research, but most people use the Bush-Francis clinically. For children, the Pediatric Catatonia Rating Scale is an adaptation of the Bush-Francis. One of the most useful investigations we have for catatonia is the lorazepam challenge. And this can be helpful if you're unsure whether a case is catatonia. And to be honest, that's not infrequent, actually. Often these cases are a little bit borderline and confusing, but it's also useful if you're pretty sure this is catatonia and you want to work out what the next steps are in terms of treatment. So you assess the baseline catatonic features, for example, using the Bush-Francis. You administer a dose of lorazepam. You get faster and often more dramatic effects if you can give this parenterally rather than orally. And then you reassess the catatonic features, do another Bush-Francis. And if there's a 50% reduction in catatonic features, it's considered a positive lorazepam challenge. And so it's helpful in that it increases the likelihood that this is catatonia if you get a positive response. Secondly, if you're really struggling with your history, it can give you a lucid window where a patient with catatonia can tell you a little bit about what's going on. And thirdly, a positive lorazepam challenge is predictive of further good response to lorazepam as a treatment. But what if it's not catatonia? What else could be going on here? There's a big differential. I'll pick out a few here. So in terms of neurological movement disorders, stiff person syndrome is particularly interesting. It presents with progressive rigidity, muscle spasms, and is associated with antibodies to GAD, glutamic acid decarboxylase. and sometimes with other components of GABAergic signaling. It's not clear whether GAD antibodies are pathogenic, but one particular feature of SPS is that it's associated with severe anxiety. So these patients often end up going down psychiatry first. It is, however, pretty rare. Parkinson's disease, again, would have a much more insidious onset usually. Dystonia would tend to be focal, or if it's generalized, would tend to have a longer history. In terms of speech disorders, sometimes you can distinguish these by getting the patient to write down if you're trying to look for anarthria. Non-convulsive status epilepticus, I've mentioned. In a liaison setting, I find often one of the most common and challenging diagnoses is a hypoactive delirium. And here I find some of the more positive signs of catatonia are helpful in distinguishing it. Though there is a growing literature on the overlap between delirium and catatonia. And you have some disorders of motivation, like abulia and akinetic mutism. I have seen some cases of functional neurological disorder referred as possible catatonia. Often, very rarely there have been some reports of functional coma, but usually I found actually they haven't been too difficult to distinguish because the FND is much more focal, whereas the catatonia is a more generalized syndrome. And sometimes we face these patients where malingering or a fictitious disorder is on the differential, and their inpatient observation looking for inconsistency can be really helpful. So that's a brief introduction to the assessment of catatonia. Let's think about the treatment now. So a few general principles. The first is that several studies have associated delay in treatment with a poorer treatment response. So I think it's really helpful, really important to start treatment as soon as possible. There are three things you want to be thinking about with treatment of catatonia. The first is specific treatment for the catatonia, which we'll talk about in a minute. The second is treatment for any underlying condition, whether that's a psychiatric disorder or a medical disorder. And the third is prevention and treatment for the complications of catatonia. And sometimes this means one-to-one observations during mealtime, encouraging oral intake. Sometimes it means intravenous rehydration, NG feeding, occasionally PEG insertion in longer-term cases. In terms of the specific treatment for catatonia, there are benzodiazepines and ECT have the most evidence, and they're both associated with 60 to 80% response rates. Sometimes it can be very dramatic. There isn't good evidence to recommend one over another. So a few things to bear in mind are the side effect profile and the importance of particular side effects for that individual. Whether they've got an underlying condition that might respond to ECT, so particularly depression, and local availability. If there's going to be a long delay for ECT, benzodiazepines are going to be a better option initially. Let's go into a bit more detail about benzodiazepines. So it's likely that the effect of benzodiazepines is a class effect rather than being specific to lorazepam, which is the most commonly used agent. In fact, it's probably broader than that. So the Z drugs, so zolpidem and essolpidem, seem to be effective for catatonia. Barbiturates used to be used for catatonia. And the Russians even used to give intravenous brandy. So it's probably not anything specific to lorazepam. Why do we say lorazepam is preferred? Well, we've got an awful lot more evidence on lorazepam. And in particular, with lorazepam, you sometimes have to titrate up to very high doses. And we understand the safety of that because we've done it lots of times in patients with catatonia. We don't really know how safe it is to titrate up, say, diazepam or clonazepam. As I mentioned, high doses beyond licensed maximums are sometimes necessary. So some patients will respond to 2 to 4 milligrams of lorazepam a day, and that's wonderful. but others both tolerate and require really high doses. And we said that actually, based on a number of observational studies, you shouldn't conclude that lorazepam has been ineffective until you've got up to at least 16 milligrams of lorazepam a day. And there are some case reports of patients requiring 20 to 30 milligrams of lorazepam a day. Obviously, you don't go there straight away. You titrate up, maybe increasing by 2 or 3 milligrams each day. And assessing as you go, so monitoring effectiveness, monitoring sedation, respiratory depression. And you want to continue your trial of lorazepam until either you've adequately treated the catatonia, or side effects prevent further titration, or you reach a high dose. You can get withdrawal effects if you withdraw benzodiazepines quickly. The most common is just resurgence of the catatonia. You can also get crippling anxiety, and we had a case report where a patient had been withdrawn from benzodiazepines too quickly, and they actually had a couple of generalized tonic-clonic seizures. So taper down, and the speed of the taper probably depends on the setting you're in. So you can probably do it more quickly if the patient is still an inpatient and you're observing them carefully. If you've been able to discharge them, you probably want to do that more slowly. Electroconvulsive therapy is also highly effective in catatonia. There's a bit more evidence for bilateral ECT. And I think pretty much all the studies, all the studies we came across had used ECT at least twice weekly. Some of them a lot more than that. The number of sessions, like as always with ECT, depends on a lot of factors, so the treatment response, risks, and side effects. There have been a lot of case reports of other treatments for catatonia. The ones that have the most evidence now are the NMDA receptor uncompetitive antagonists, memantine and amantadine, which are interesting medications. So memantine, should be aware, is used for Alzheimer's disease. Amantadine was developed as a treatment for influenza, but is now used in Parkinson's disease, both for improving the rigidity and the bradykinesia, but also actually in reducing the drug-related dyskinesias you get in Parkinson's disease. They're both reasonably safe to use, but have a couple of quirks. So they can lower the seizure threshold, and amantadine can cause a rash, libido reticularis. Antipsychotics should be avoided where there's no underlying psychotic disorder. And the reason for this is that catatonia is really a very strong risk factor for neuroleptic malignant syndrome. And where there's no underlying psychotic disorder, there doesn't seem to be an indication for antipsychotics in catatonia. However, quite often you're in a situation where you're convinced that the catatonia is being driven by active psychosis. And there is an argument that you should use antipsychotics, but do so cautiously. So titrate slowly, have benzodiazepine cover. Okay. In terms of subtypes of catatonia, I'm going to go through this briefly and start with periodic catatonia, which is an interesting condition where there's these rapid onset, brief and recurring episodes. The episodes tend to last a few days, and then the remission periods can really be quite long. Normal treatments for catatonia probably work acutely, but there's a little bit of evidence that in the maintenance phase, prophylactic lithium can reduce the frequency of episodes. Malignant catatonia is catatonia where you have hypothermia and autonomic dysfunction. Treatment is to stop dopamine antagonists, lorazepam and ECT. Neuroleptic malignant syndrome is arguably a form of antipsychotic-induced malignant catatonia. And there have been studies showing that it's actually very difficult to untangle the symptoms and signs of NMS versus malignant catatonia. they do have a number of similarities. Stop dopamine antagonists in lots of studies seems to be the biggest factor, although again, there's an absence of RCTs at NOS. Also stop anticholinergic drugs, which can prevent successful thermoregulation. Supportive medical care. In milder cases, consider benzodiazepines, and in more severe cases, consider the dopamine agonist, bromocriptine, amantadine, dantrolene, and ECT. Antipsychotic-induced catatonia occasionally happens, probably more commonly with first-generation antipsychotics. As you might imagine, you want to stop the antipsychotic, and if that doesn't work, you can give a benzodiazepine. Special groups. I'm just going to go skip forward to autism, because I think that's particularly is a little bit distinctive, actually. So Lorna Wing, a British psychiatrist, described catatonia and autism about 20 years ago. Catatonia does seem to be common in autism, so be on the lookout for it. However, there's a big caveat, and that's that there's a lot of overlap actually between some of the features of autism and some of the features of catatonia. So if you think about the slightly awkward postures you get in autism, or stereotypies, the mannerisms, even echolalia. So to identify catatonia, you really want there to be a marked change from baseline. The treatment is a little bit different as well, in that in milder catatonia, and you do in autism sometimes get these milder, very chronic presentations of catatonia. There are specifically designed psychological interventions, notably, and they're very behavioral. So it's a mixture of getting a very structured routine on one hand, and also developing prompts, verbal and sensory cues for individuals when they freeze doing tasks. And lorazepam, if that doesn't work, and then in more severe cases, use the normal treatment algorithm. Okay, so key points. Diagnose catatonia on the basis of at least 3 signs. Use the lorazepam challenge when you're in doubt. A wide range of medical and psychiatric conditions can underlie catatonia. Consider investigations according to the clinical picture, and we'll go on to that in a minute. And first-line treatment is lorazepam and/or ECT. So that's a very brief summary of the BAP guidelines. What I want to do now is talk about some of our research findings, focusing on the role of clinical investigation of catatonia. So I've been interested in inflammatory markers in catatonia for a little while, and we wrote this review back in 2019, where we looked at all the cases of catatonia related to inflammatory and autoimmune conditions. And we found that of about 350 autoimmune conditions associated with catatonia, about 250 of them were related to one condition, and that is NMDA receptor encephalitis, which is quite stark. If you look at the studies of NMDA receptor encephalitis, where they've systematically ascertained the presence of catatonia, the largest one here found a prevalence of 88% catatonia among these cases. Overall, it was about 64%. So catatonia seems to be a big deal within NMDA receptor encephalitis, and seems to fall at a particular point in the condition. So if you start with non-specific flu-like symptoms, develop anxiety, psychosis, then catatonia, seizure, coma, death, being the typical trajectory, it often comes in. So we wanted to investigate whether, so we knew that catatonia was a common feature of NMDA receptor encephalitis, but what we didn't know is whether antibodies to the NMDA receptor might be a common feature of catatonia. And that could lead us to wondering whether there are cases of NMDA receptor encephalitis underlying more cases of catatonia than we'd hitherto appreciated. So I used anonymized healthcare records from South London and Maudsley as part of a CRIS system. So it's about 400,000 patients. We identified about 1,500 individuals with catatonia across 2,000 episodes. And we were the first people to be able to calculate a population incidence of catatonia, which made it about 1 per 10,000 person years. And I hope that the process would look something like this for extracting the data, but actually myself and 2 medical students looked much more like this as we were hunched over computers trying to extract these data. I'm going to skip out some of the epidemiological findings and focus on some of the blood-based markers. Now, there's been a finding going back about 3 decades of low serum iron in catatonia. Sounds a bit implausible, so what on earth could be going on there? But actually, I was quite surprised that we replicated that result, albeit it's not a huge difference. So iron in the catatonic patients was 11.6 compared to inpatient controls of 14. The findings for CRP and white cell count were really quite underwhelming. What was very stark is that the patients with catatonia tended to have a very high creatine kinase. Lots of possible reasons for that. It might be the muscle rigidity, or it might be the pressure, the pressure sores developing. What about NMDA receptor antibodies? So 3 out of 54 catatonic patients who had NMDA receptor antibodies measured in serum were positive, compared to 5 out of 480. So about 5% compared to 1%, which did give an odds ratio of about 6. We adjusted this for age, sex, and ethnicity. But I'd forgive you for a bit of skepticism about these results, given that it's only based on 3 patients. So, what can we conclude about blood-based biomarkers in catatonia? CK tends to be high in catatonia, but it's not very specific. So CK can be high because of neuroleptic malignant syndrome, because of myocardial infarction, because of receiving an intramuscular injection, or because of running around Camberwell. The CRP and the white cell count were not very promising, but antibodies to the NMDA receptor were much more interesting. Of course, you've got to bear in mind, with all this research using electronic healthcare records, that there is vast amounts of missing data. So out of the 1,400 catatonic patients, only 54 of them actually had the antibodies measured, and maybe there are biases towards measuring it in particular catatonic patients and not in more so than in the controls. So this has been the wake-up call to do a prospective study, and I've been spending the last couple of years cycling around London, recruiting patients with catatonia, taking blood samples from them. So we'll be able to do this much more systematically. So those are the blood-based inflammatory markers. I want to talk about structural MRI now. And I should say from the start that these findings are based on neuroradiologist reports rather than quantitative analysis of the scans. And the good thing about that is that it's quite clinically relevant. So we examined the MRI scans from the patients that we'd identified in the previous cohort. And we did a case control study, so looking at catatonic patients versus our inpatients controls, trying to see whether having an abnormality reported on your MRI scan changed your probability of having a catatonia diagnosis. So 1,400 catatonic patients, 79 of them had scans, and we, among our control group, we had about 700 scans. comparing just the crude numbers of scans that were abnormal. So among the Catatonia group, 34% were abnormal, but among the comparison group, 48% were abnormal. And this is a bit of a surprise for us because I've told you all the different neurological and medical conditions that can trigger catatonia. And then we found more or less the exact opposite. So, of course, we didn't just do a univariable logistic regression here. We added in some potential confounders. So sex, race, ethnicity, but the big one was the diagnostic group. And you can see here that only 4% of the catatonia group had a diagnosis in the organic or neurodevelopmental categories, compared to 17% of the comparison group. And the vast majority of these patients had dementia. So the comparison group was massively enriched for patients with dementia who are going to have abnormal MRI scans. So when we adjusted for these variables, we got an odds ratio of 1.1 with a pretty wide confidence interval. There's still the problem, though, of all the people we're not scanning. 90% of people are not getting a scan more than that. And there are going to be big biases in the patients who do get scans. So we then conducted multiple imputation where we tried to take that into account. We got a very similar answer, odds ratio of 1.3, but now the confidence interval was even larger, between 0.5 and 3.2. So 79 scans of catatonia patients, which is the largest number of scans of catatonia patients ever to make it into the research literature, was nowhere near enough to answer this question with anything like a meaningful degree of precision. So are MRI abnormalities more common in catatonia than other SMI patients? Actually, we still have no idea. And again, there needs to be a prospective study on this. Finally, so we talked about blood-based inflammatory markers. We've talked about structural MRI. What about the electroencephalogram, the EEG? And the question that we wanted to answer here was, does the EEG usefully distinguish so-called psychiatric cases of catatonia from medical cases of catatonia? And in a liaison psychiatry context, that's often a very live issue because it determines where the patient is going to be treated, by whom they're going to be treated, and often the kind of treatment they're going to get. The EEG has a long history in psychiatry. It was actually invented by a psychiatrist, Hans Berger, in the 1920s and 30s. But it never took off. He was interested in, he invented it because he was interested in finding a neurobiological substrate for psychiatric disorders. But he died disappointed that that was not realized. It does, however, have a number of applications to psychiatry. So one is in the identification of delirium, where you get generalized background slowing. Another is in distinguishing epileptic seizures from functional or dissociative seizures. There's also more recently, so 2007, NMDA receptor encephalitis was identified, and this has a distinctive signature on EEG, which is the extreme delta brush. And finally, there's the non-convulsive status epilepticus, which can occasionally mimic primary psychiatric disorders. So the EEG hasn't quite lived up to its Berger promise in psychiatry, but it's not useless in clinical psychiatric practice. What we wanted to do here was to ascertain the performance of conventional EEG in identifying whether catatonia has a psychiatric or a medical cause. So again, we weren't looking at the quantitative EEG studies. We're just looking at clinical EEGs where you show a neurophysiologist a trace and they use their dark arts to work out what's going on. And we didn't have data of our own, so we did a systematic review and meta-analysis. We searched 4 databases: Medline, Embase, PsycInfo, and AMED, looking for combinations of catatonia and EEG with their synonyms. We included a really wide range of studies because there was not a lot out there. So we even included individual case reports, but I'll talk in a minute about how we handled them. They needed to have a clinical EEG report and some clinical diagnosis. We initially identified 1,600 patients in the search, and we ended up including 355 studies. This covered 707 patients, and we divided them into the larger studies and smaller studies. So larger studies had at least 5 patients, and these were really helpful because there's going to be less reporting bias in these studies, and they're suitable for formal meta-analytic methods. There were 12 of these studies with 300 patients. Why then did we include, given that we had some larger studies, why did we bother including smaller studies? Well, they had a few advantages. Often the larger studies would only give very sparse details about the EEG and very little detail about the patients, whereas the smaller studies were often case reports that would go into beautiful granular detail about who the patients were, what their past neurological and psychiatric history was, how old they were, and then would give a much more detailed report of the EEG. So we used both of them. In terms of the meta-analysis, this gave us, so we had our predicted values based on the EEG, which might be positive, an abnormal EEG, or negative, a normal EEG. And then we had our actual values, so our patients with a neuromedical catatonia and patients with a psychiatric catatonia. With our larger studies, we conducted a formal meta-analysis. Now, when you're doing a meta-analysis of diagnostic test accuracy, it's a little bit different to meta-analyses of prevalence or treatment effects, because you're trying to model 2 things simultaneously. You're trying to get the optimal sensitivity and specificity. And you need to do this together because those 2 things tend to be closely related. In fact, they tend to be negatively correlated, as you might expect. If you ramp up your sensitivity, you're going to lose a little bit of specificity. So we used a bivariate model that took this into account. With the smaller studies, we just added up all the cases in the 4 categories because they can't use studies of this size in a meta-analysis of this type. Here are the 11 larger studies with a range of specificities and sensitivities. Sensitivity maybe looks a bit more consistent than the specificity, actually. And these are the studies where we were able to calculate both sensitivity and specificity. And again, you can see that, that trade-off between sensitivity and specificity. So overall, we found a sensitivity of 82% and a specificity of 66% for detecting a neurological or medical cause of catatonia compared to a psychiatric catatonia. You can then use this plot. So if you have a prior probability of catatonia of 50%, and you use, and you then get you've got a prior probability of 50% on the x-axis, and you have a negative test result, you end up with a posterior probability of 20%. So that's if you get a normal EEG. But if you've got a prior probability of 50% and you get an abnormal EEG, you end up with a posterior probability of 70%. So the EEG is not definitive. It's not the only piece of information you want, but it is quite helpful, I think, to move you from 50% to start with to 20% or 70%. And obviously you can have your different prior probabilities to enter into that. So we conducted a number of sensitivity analyses where we excluded studies that were published prior to 1980, excluded studies with lower confidence in the reference standard, and we continue to get very similar results. Well, those were the larger studies. Look at the smaller studies. Again, we got something quite similar, so a sensitivity of 76%, a specificity of 67%. In terms of the particular abnormalities, among the medical catatonia cases, there were quite a lot of cases of this generalized background slowing, features of encephalopathy, some features of limbic encephalitis, epileptiform discharges, focal abnormalities, and some status epilepticus. So, what's driving this low specificity? You'd think that an abnormal EEG tells you that there's something neurological going on. Surely, if we trust the EEG. And I think the answer is in the particular abnormalities. So when you break it down and look at the sensitivity and specificity of the EEG by different abnormalities, overall, the specificity about 67%. We've got some really specific abnormalities, features of limbic encephalitis, epileptiform discharges, focal abnormality, status epilepticus, almost 100% specific for a neurological or medical cause of catatonia. Whereas features of encephalopathy is much less specific. So the way you interpret your EEG needs to be much more than is it normal or abnormal. You need to go into the specific abnormalities. So is the EEG useful in determining the etiology of catatonia? Yes, but a normal EEG is more helpful than an abnormal one. Generalized slowing is not very specific. The extreme delta brush, interictal epileptiform discharges, focal abnormalities, and status epilepticus are all really useful, actually. So what can we say about investigations in catatonia? Antibodies to the NMDA receptor may be more common than in other psychiatric patients. MRI abnormalities, still very unclear what's going on in catatonia, if anything. In terms of the EEG of catatonia, it's often abnormal, but it can be a useful component, a useful part of your workup in determining the etiology of catatonia. So what do we say in the end about investigations for catatonia and the BAP guidelines? Well, it was hard to give a one-size-fits-all because sometimes there are patients who come in and it's very clear what's triggered the catatonia. A patient who stopped their clozapine 2 days earlier, for instance. So it's got to be personalized. We suggest there are blood tests, urine drug screen, lumbar puncture, EEG, and neuroimaging to consider. And then we made a couple of more specific recommendations. So if a first episode or diagnosis is unclear, consider neuroimaging and autoantibodies. We agonized a little bit about this sentence here because there's only really good evidence linking catatonia to NMDA receptor encephalitis. It's just case reports linking to various other forms of autoimmune encephalitis. But the problem is, if you're doing a lumbar puncture, you don't want to have to do it multiple times. So you want to test various autoantibodies when you do it. If there are risk factors for seizures, there's possible evidence for a seizure or possible encephalitis, you do want to do an EEG, ideally with continuous monitoring. So this is the link to the guidelines. I'd be very interested to hear your thoughts about catatonia and any questions you have.
So many thanks, Jonathan. I think I should have praised you more before, so wonderful talk and I'm very grateful.